I'm very excited today to talk about the UC DOSE project, which is a collaborative project across the University of California medical centers. So the UC DOSE stands for University of California Dose Optimization and Standardization Endeavor. The University of California includes 5 distinct medical centers. It's UC Davis, UCSF, UCLA, UC San Diego, and UC Irvine. While there are many scientific collaborations that go on across the 5 campuses, and there's some shared oversight by the University of California Office of the President that oversees all of the University of California campuses, both those that are medical and those that are not. We're really separate, independent institutions with separate electronic medical records, and really at this point has not been the most meaningful integration across the hospitals. They're interested in creating more integration, but so far we're freestanding institutions. And in 2011, I sought funding from the University of California Office of the President to basically try to create a quality improvement project through funding for the Center for Healthcare Quality and Innovation to begin collaborating across the campuses on issues around radiation safety and imaging, both for clinical improvement, mostly for clinical improvement, but also for research purposes. And really the support for the University of California Office of the President is really what led to this virtual meeting. A little bit of background about the UC DOSE project. We have incredible expertise on each of our 5 campuses around issues related to radiation, dose optimization, physics, medical imaging, but there's been little formal dialogue or shared assessment. And so the purpose of this project was to begin formal collaboration among radiologists, physicists, and technologists across the campuses. Our goals were to begin standardizing doses. That meant optimizing doses and minimizing doses, to benchmark doses, what's the right amount to use for different indications, to establish standard protocols, which we're hoping to make widely available, to educate the UC University of California staff as well as the broader community about CT radiation dose reduction techniques, which is the initial thoughts of this meeting came from this initial grant proposal, as well as part of the grant proposal was to develop consensus around the best way to assess and report dose information to comply with the California law SB 1237 requiring reporting radiation dose information. So this is a photo of our initial meeting. Most of the people on this slide, you'll have a chance to meet several times at this meeting giving talks, but a really wonderful group of collaborators who are willing to jump in. On this slide, I'm just showing you that we have representatives of all of these groups, physicians, physicists, technologists, as well as program managers. And it's really been very exciting to get to collaborate with these individuals for this project. Our main initial priority was to figure out how we're going to assess dose. And we needed a simple tool that we could use in real time, meaning we could use it over and over again throughout this 3-year collaboration, not just one time, to collect and assess radiation dose across the campuses. We discussed our needs with several software vendors, and we settled on one that allowed us to easily pull data from across the 5 sites in a HIPAA-compliant fashion and pull the data on a single server located at UCSF. This was incredibly helpful to us because now all of a sudden, instead of having 5 separate campuses which have no ability to pool data, we have one central registry where we're looking at the data and allows us to move forward. We used Radiometrics for this purpose, and it's been very helpful for us. We are just beginning to assess dose in terms of similarities and differences across the campus, and I wanted to use this time when I'm speaking to you to give you a little bit of sort of the workings of what we're up to, not so much our final results. I have no pool of standard protocols to share, but rather how we're thinking about this, because I think this provides a model for many organizations, be it several different hospitals within one HMO, several different hospitals that belong to a hospital chain, several different outpatient clinics, to begin working together to improve the quality of what they're doing. So the first step in thinking about how to assess dose is to figure out how you organize the examinations that you do within what I'm calling appropriate bins. So it's just a simple example. You can't really compare a dose for a head CT to a dose from a belly CT. Obviously those are very different. And so you have to figure out how to organize the examinations that were done. And there are lots of different ways for doing this, and I want to go through a few of them to just highlight sort of what I think is important. Once you come up with those bins, you can then start to summarize dose, look at dose within different groups to determine where there are differences, where there are outliers, where doses are being optimized and where they're not being optimized. One way to do this, which I think gets a lot of play, is to organize the dose by the protocol. I'm not very excited about this approach, and I want to walk you through why I'm not that excited about the approach. But I don't think organizing exams by protocols really gets at what we want to do. And I'm going to go through a few examples to explain why that is. But the question that I think is important to get at when you're assessing dose is if a patient, Mrs. Jones, is going to a facility to get a head CT or to get a study to make sure she doesn't have kidney stones, she should sort of get the same dose wherever she goes. And that's the question that we're wanting to answer. And then I want to figure out how do we bin the studies at facility A and B to figure that out if she's getting the same dose or not. And I'll give you examples with renal stones and pulmonary embolism as two examples. I will say that I think the best way to organize studies is by anatomic area, but we'll get to that shortly. So for kidney stones, let's imagine that a facility, let's say our facility, UCSF, has several different ways that patients can be sent to evaluate kidney stones. We have a low-dose kidney stone study, which is specifically designed to look for kidney stones. It's got one pass, non-contrast. And then we also have a study that's a multiple-phase study that can be done for kidney stones patients. I think everyone would agree that the ideal situation is to just send a patient who you're looking for stones for a renal stone study, but in fact that's not what happens in clinical practice. What happens in clinical practice is that many patients who were sent for by the emergency physicians look for kidney stones end up in the bin of getting these multi-phase studies, which does answer the question but does so at a much higher dose. If you have differences at two different facilities where they use the different protocols with different frequencies, the patient, Mrs. Jones, who's going to facility A and B, might have, in general, 3 times the dose if she goes to facility A than facility B, because facility A tends to use the multi-phase protocols more often. If you only look within protocols, the dose within the multi-phase protocol might be the same at A and B. And it might be the same for the renal stone protocol, the low-dose protocol A and B. It may be 15 for one and 4 for the other, and it might be the same across facilities. But if at the facility A, they use the multi-phase study more often, in general, patients who go to that facility, even if they're going for stones, have higher doses. And that's a problem. And it's a problem that we want to understand when we're comparing how we're doing. And the only way to understand that is to kind of look at patients who are getting sent for rule-out stones, not by looking at what the protocols had doses associated with them. As a separate example, you can look at patients who are being evaluated for pulmonary embolism. And we have the exact same situation. Patients can be sent for a higher dose study or the lower dose study, and depending on the referral patterns within that hospital, which I will say vary by the time of day, by the technologist, by the physician who's reading it, the doses can be very different, and yet within the protocols, the doses can be just fine. So you may not be really learning about what a facility is doing if you only look within protocol. The other problem is it's hard to understand the protocols that we're using. It would be nice if we could start from scratch and create new protocols, but in fact within every institution we have so many protocols, they're not so easy to organize. I'm giving you an example here of some head protocols across one of the UC hospitals. And you can see that there are some dominant protocols at the top. That one's used most often, although there are lots of other protocols below. You can't tell from the names of these, for most of them, exactly why one of these subarachnoid protocols is being used versus another subarachnoid protocols. The names themselves don't really help you categorize them. And the highlighting shows you the protocols that have higher dose versus lower dose using a statistical method to figure out outliers. And you can see there's an enormous variation between the very red squares, those are very high dose, and it's not clear that there's clinical indication behind who gets assigned to different protocols. This is looking at the same kind of information for abdominal pelvic scan. I don't want to say that I'm not interested in organizing these protocols. I am. But at this point, there's a lot of work to be done to organize the protocols, and really I care about who's getting the protocols rather than exactly what the dose is within those protocols. It turns out there are a lot of newer high-dose studies that we've been using lately, and these are sophisticated imaging techniques that absolutely might have a role in diagnosis. For example, looking at brain perfusion scans. But there are very few evidence-based guidelines about when to use these studies. And there's profound practice variation. And this reflects physician preferences, promotion of these capabilities by manufacturers, rather than evidence of improved clinical outcomes. And so part of the variation in all these protocols is it's sort of almost at a whim what different facilities do, what different doctors do, what different manufacturers have as the default. And when these protocols are chosen, public health safety concerns to minimize dose has not been paramount to those tasked with buying the equipment or with setting up the protocols. And that's sort of why we have so many differences. They really vary by so many different factors that are not related to what the clinical question is that needs to be answered. I know at our institution some doctors like higher dose studies for the same indication than others. And I would argue that liking a higher dose study is not the same thing as making it a more diagnostic study. And I think we need to focus on making studies diagnostic at the lowest dose possible. This is an example of a slightly different situation, but these are two images on the left, up and down, one study period, on the right a second. This is a patient who had a pulmonary nodule that needed surveillance at the same institution, was sent at 2 different times, and at one time had a dose of 1.5 millisieverts on the left, this low-dose lung cancer nodule screening protocol, and on the right had a routine chest with a dose that was 10-fold higher. If you look at doses within protocols, the left dose would look good, a low-dose protocol study with 1.5 millisieverts. That's beautiful. If you look on the right, you'd say multiphase routine chest CT. Fabulous. Dose of 15.9, that's okay. The problem was where the patient was sent, not in the protocol itself. And so if you look at dose within protocol, you miss this piece. So the real way we want to get it looking at dose across site is by indication, why the patient was sent. Those are the examples I keep giving you. This is ideal. This is what the patient, the physician, and you at your institution want to know. I'm showing you a slide from a paper we published in the Archives of Internal Medicine in 2009. This is looking at 4 San Francisco Bay Area institutions. And for this, we were looking at doses by indication. So if you look, let's say, at the row that said suspected pulmonary embolism, we didn't look at the protocol as much as what the clinical indication was. You can see for that exam type, 3 of the facilities had doses around 8 and 9 millisieverts, and the last one 21. So this is the kind of information you really want to get, and we learned a lot about why Site 2 had higher dose, and this kind of information was great. The problem, it's very difficult at this point to look at indication. We are working on it. That's the focus of our Year 3 UC Dose project, but we're not that year. We're not there yet. But we start to want to look at dose. How are we going to do that? I don't think looking at protocol is terribly useful because it doesn't in any way mimic indication. We're not at indication. So the way that I think it's right to move forward, and that's how we're moving forward, is we're organizing it by anatomic area. It's not perfect, but it's the ideal way to start. And in general, differences across sites in the patient referral shouldn't be that different. So at UC Davis, there might be a little more trauma patients than at UCSF, but at both of our facilities, we see a whole range of patients from those who we're looking for, let's say, strokes or trauma or evaluation of a headache, and there's a mix, and thus overall organizing by anatomic area seems the right way to go and will get us to where we're going. So this is a slide of looking at one facility on the bottom compared to the other 4 facilities. And what you can see, and we can actually provide this information to you, any facility that would like to start getting audits in the format that we're showing you here, you can log on to our website and we'll help you figure out how to send us data and we'll help you get an audit. But this shows that one facility's dose is 3 millisieverts on average for a chest exam compared to other facilities are 9 millisieverts. Huge difference by chest. Has nothing to do with the differences in patients. This is actually limited to adults, but is a way to start. This is another example looking at brain scans, and you can see that The bottom facility is one facility compared to the top distribution. The top distribution shows that most facilities have two types of protocols, a higher and a lower dose one. You see those two distributions. Where the bottom facility only has a single distribution, on average they use a slightly higher dose, but they don't use the high dose studies. And I think there's a lot to be learned from looking at this, and the anatomic area is the way to do so. We're also looking, and again will be provided in the audits if you choose to look at it, is the dose within anatomic area by machine. So I've highlighted one machine here, and here I've showed you three anatomic areas: the abdomen, the chest, and the head. And here I'm showing you a metric of the dose, the DLP. And what you can see is that one site highlighted on the right, in general, for this one machine, has a DLP that's about 40% lower than the other slides. They're doing something right. Obviously, this doesn't tell us about their diagnostic accuracy, but in general, they're doing really well in the abdomen in terms of the dose. Of course, we have to make sure that their quality is good, but the dose is lower, where the other anatomic areas, chest and head, are kind of closer to the mix. Another way that we're looking at dose is here stratified by anatomic area and stratified by machine. And here, this is what our audits are looking like. You can figure out the red highlighted cells show this facility has doses that are higher on average, the blue lower than average. So this facility has decided not to focus on head where they're doing great, but to start to examine their doses. And at the facility level, they absolutely need to start looking at their protocols. But by organizing the assessment by anatomic area, that's a way to start. There are two other projects that we have been working on within the UC Dose collaboration. One of them is how to respond to the California Legislative Bill 1237. This was the first legislation in the U.S. focused on CT. Obviously, we have other bills now that have passed. Ours went into effect about a year ago. It requires reporting of the CT dose for every exam in the medical record. Dose errors have to be reported, dose have to be verified, and we actually developed a guidance document, which of course you can download from our website. We're happy to share, on our beliefs of how to comply with the law. I'm a big fan of the law. I think collecting data is incredibly important to begin to look at how we're doing, although if we don't collect data in a similar way across facilities, it's less meaningful, and thus we created a guidance document both for our own internal use and to share with anyone else who's interested. Lastly, we have tried and have begun to engage technologists in our work to standardize and optimize doses. In fact, the initial focus of this meeting that has become a virtual meeting was really to educate the technologists. But what we've learned is that it's very important for the technologists to begin to educate both us, sort of the physicists and the physicians, as well as each other. And we are trying, and I think we're being successful, engaging the technologists, who are the people who really make most of the decisions about what goes on for the patient, to both engage them in making informed decisions that will help our patients. And it's been very exciting for us that many of the technologists who are involved in the project have been meeting on their own, have been having conversations on their own to share techniques of what they know on how to lower dose, as well as to give feedback to us on what works and what does not work. So that's been another very exciting part of our project. So thanks for the opportunity to share work on our UC Dose collaboration. It's been a pleasure to work with the UC physicists, radiologists, and technologists on this project. Thanks very much.